Welcome back, everyone. We're going to continue down our neurology series with looking at stroke and TIA. Stroke, as it's referred to today, formerly was called Cerebrovascular Accident. We did away with the term CVA or Cerebrovascular Accident several years ago because it's not truly an accident. There are correlating risk factors and preventative measures that can be taken, such as management of hypertension, that really lead to the likelihood of a patient having a stroke. And so we moved away from CVA in favor of stroke because of that. A stroke is an interruption of blood flow to an area of the brain. That impacted tissue is called the penumbra. It can result in a loss of brain function, and there are two main types of stroke that we're going to discuss today, the ischemic stroke and the hemorrhagic stroke. The ischemic stroke is a stroke that results from a thrombosis or an embolus, and it accounts for about 87% of all strokes. Symptoms can range from nothing at all to complete paralysis or hemiparesis. Atherosclerosis in the blood vessels is often the cause, and this is that buildup of plaque. And when that plaque breaks free, we call that a thrombus, and that moves throughout the body, an embolus, and moves throughout the body and can lodge itself in some of the terminal circulatory pathways. And the two predominant organs that are at risk for that are the brain and the lungs. And the lungs, we call that a pulmonary emboli. And when it lodges itself in the brain, we call that a stroke. Hemorrhagic strokes account for about 13%. It's a result of bleeding inside the brain. Cerebral hemorrhages are often fatal, and people at high risk include those experiencing significant stress or exertion, with the highest risk factor of those having uncontrolled hypertension or high blood pressure. If you'll remember back from our anatomy discussion of the neurologic system, the brain is a very vascular organ, and so a rupture of these vessels can occur any number of places within the brain. And because the cranium is a vault, the skull is an enclosed space, free bleeding in that space causes pressure to increase across the brain and within that cranial vault, and thus we can see symptoms that are global in nature for these patients. One of the congenital causes of hemorrhagic stroke is an aneurysm. This is a swelling or an enlargement of the wall of an artery resulting from the defect or the weakening of that arterial wall. This can lead to a bulge and could possibly rupture in a patient, thus leading to hemorrhagic stroke. Transient ischemic attacks are stroke-like symptoms that go away on their own without intervention within less than 24 hours. These can present just like a full stroke with large vessel occlusion type symptoms, but can resolve oftentimes in a very short period of time with no indication of onset or resolution. They should be treated with care, though, because it might be a warning sign of a larger stroke to come later, and about 1/3 of patients who have a TIA will experience a stroke. Looking at signs and symptoms of a stroke, the symptoms and the signs presenting from that patient are wide-ranging. You can see here an extensive list, including facial drooping, decreased or absent movement or sensation of one side of the body, lack of muscle coordination, that term is ataxia, blurred or double vision, difficulty swallowing, changes in responsiveness and speech disorders, things like aphasia or dysarthria being slurred speech, sudden or severe headache, coma, tongue deviation, combativeness, weakness, dizziness, confusion. This is why it's important that when we have patients with altered mental status, that we perform at least a rudimentary stroke assessment to increase or decrease the likelihood that that patient may be experiencing a stroke. We used to use the Cincinnati Prehospital Stroke Scale to assess for strokes, and we still see this today in teaching the lay provider or the lay person how to recognize stroke. It's characterized by facial drooping, arm drifting, or dysphasia, so speech deficits. In EMS today, we commonly use scales like the RACE scale or RACE score, and this is an EMS assessment tool for acute ischemic stroke. It has an 85% sensitivity, but a specificity of only about 68%, and this is the scale's ability to identify either false positive or false negative based on that stroke. It's a far better tool than just the Cincinnati Prehospital Stroke Scale, and it helps us make significant transport decisions for these patients to make sure that those suspected of having a large vessel occlusive stroke are making it to the appropriate facility for further assessment and treatment. We use the areas here, the categorized on the test item on the left-hand side of the scale. So we're looking at facial palsy, arm motor, leg motor, head or gaze or deviation, aphasia if it's right-sided hemiparesis, and agnosia if it's left-sided hemiparesis. And so for palsy, arm motor, and leg motor, scores range from 0, 1, and 2. Whether they're for palsy, if it's absent, it gets a score of 0. For arm motor and leg motor, if they're normal, it also gets a score of 0. If there's severe deficiencies in the arm and leg motor movement, arm or leg motor movement, those are ranked as severe and given a score of 2 each. The same with facial palsy. If there is significant palsy within the patient's facial muscles, so that facial drooping, they would get a score of 2. If they have right-sided hemiparesis, meaning if the affected limbs on the right are on the right side of the body, then we'll perform the aphasia test. We'll ask the patient to close your eyes and then make a fist, and we're looking for if the patient can perform both of those tasks, so both closing your eyes and making a fist, only perform one, or can perform neither, and we would score those accordingly. And if the patient presents with left hemiparesis, then we would use agnosia. And for this, we would ask the patient to evaluate the recognition of deficit. So if the patient has left hemiparesis, we would show them their left arm. And while showing their arm, we would say, whose arm is this? And then we would ask the patient, can you lift both arms and clap? If the patient's unable to recognize their arm, that would be worth 1 point. If they're unable to recognize both arm and impairment, they would have a score of 2. And if they recognize the arm and impairment, then they would have a score of 0. A race score of 5 or greater is a high indication that the patient was having an ischemic stroke with a large vessel occlusion and should be transported to a stroke center. Advanced level providers should be prepared for these patients to degrade and should prepare for things like seizures, loss of consciousness, and airway management. A left hemispheric stroke is a stroke in the left cerebral hemisphere, and it can cause things like aphasia, which is an inability to produce or understand speech. They may have memory problems, slow and cautious behavior, and speech problems can vary widely from person to person. They may also cause paralysis of the right side of the body. For right hemispheric strokes, it can cause paralysis of the left side of the body. Usually patients can understand language and are able to speak. Patients may be oblivious to their problem. It's called neglect. Neglect and lack of pain can cause many patients to delay any seeking of help, which can, as we know, time delays can cause longer outcomes or worse outcomes as that time gets longer. Hemorrhagic strokes or bleeding in the brain. These patients can be particularly brittle and progressive in their deterioration. And advanced level providers here should be prepared for things like intubation, airway management, seizures, and other significant problems. Patients typically have high blood pressure associated with hemorrhagic strokes. This is part of Cushing's triad. And Cushing's triad is 3 symptoms of presentation that's characterized by bradycardia, or low heart rate, hypertension, high blood pressure, and irregular respiratory patterns. And that can be things like Biot's or Kussmaul's, any number of irregular respiratory pattern. The high blood pressure can either be the cause of the bleeding or may be a subsequent sign or symptom of the hemorrhage itself. Increasing blood pressure is an important sign, and it's a progressive sign, and as Cushing triad becomes present, we run the risk of a patient presenting with what's known as herniation syndrome. This can lead to significant airway compromise, seizures, decorticate and decerebrate posturing in a patient, and can be very risky if not managed appropriately. These are emergent patients and should be transported to a comprehensive stroke center if one is available. Significant drops in this patient's blood pressure may occur as the patient condition worsens. This is a deteriorating patient and is likely in the peri-arrest phase. Conditions that can mimic a stroke, things like hypoglycemia, low blood sugar, postictal state, as we mentioned in the seizure lectures. So patients that are post-seizure may have similar stroke symptoms. Subdural and epidural bleeding can also present with stroke-like symptoms. So it's important as part of our assessments, we're getting a good history. Last known normal is an important one of those questions to try and identify, as well as any history of recent seizures and evaluating a patient's blood sugar. As far as management of stroke, at the basic life support level or the BLS level, we should begin with standard care guidelines, supporting things like ABCs, ensuring the patient is oxygenating appropriately, and when hypoxic, applying oxygen. Advanced level providers that have the ability to establish IV access or establish ECGs, both of those should be in place. If the patient has a fever, you should notify the receiving facility or the online med control as soon as possible. Administer fluids as needed, withholding fluids on hypertensive patients, but if the patient is hypovolemic and hypotensive, we should be administering fluid. Elevate the head of the patient's bed at least 30 degrees. This can be done by any level of provider, and airway patency can also be done by any level of provider. Watch for seizures and monitor blood pressure closely. High levels of CO2 can cause vasodilation of the cerebral arteries, and diminished carbon dioxide can lower ICP. Should a patient be experiencing herniation symptoms, and this is for advanced level providers only, paramedic providers only. If a patient is herniating, that means Cushing's triad is present, they're rapidly deteriorating, online med control can be sought and consulted for potentially permissively hyperventilating the patient to reduce the level of carbon dioxide to try and slowly diminish some of the increase in intracranial pressure. This is a double-edged sword in that hyperventilating a patient can cause other metabolic issues and really should be consulting online med control prior to this step. But it is an additional avenue that can be taken to try and buy the patient a few extra minutes while you're awaiting arrival to the comprehensive stroke facility. EMS providers should also be involved in educating the community about strokes. Prevention is key here. As we mentioned in the beginning, strokes are not accidents. Strokes are preventable and mitigatable under most circumstances. And part of our involvement with the community should be in helping prevent strokes through patient education, as well as helping educate the public on recognition of a stroke, because time is tissue and a delay in patient care ultimately can impact their recovery. Standard stroke care includes titrating oxygen, maintain an SpO2 reading of 94 to 99%. Please do not dump high flow oxygen on patients that are not hypoxic. We need to ensure that we're only administering a medication to patients when it's indicated, and the indication for oxygen administration is hypoxia. Target your SpO2 to 94 to 99%, and then tailor it back. If available, you should complete your fibrinolytic checklist, and you should be notifying your receiving facility as early as possible that you're en route with a stroke patient so they can prepare the facility and prepare the interventions and assessment techniques that may be needed.